26.
All right, very good. Welcome, everybody. My computer doesn't seem to work today, and so I'm going to just be reliant upon Nagla for you to. I'll let you look at watch your computer, but let me know, if there's hands raised or whatever else that I need to jump into. But again, appreciate everyone's time today. A couple of things we have to remind everybody as we start the meeting. We can't use chat. If you have something, if somebody puts something in chat because of the Open Meetings Act, you unfortunately have to hear me read it out loud to everybody for it to be in the record, and no one wants that to happen. So again, please don't use that, and we will go ahead and get started. The first item of business is the approval of the minutes from March 30th. If everyone could take a quick look at that, and after you've reviewed that, if I could get a motion to approve. In a second.
So moved.
So moved. Dr. Ibrahim, do you have a second? Second, Dr. Nemiroff. Any further discussion? Hearing none, all in favor, signify by saying aye.
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 Opposed, nay. Anybody abstain? Let the record show we got unanimous approval for the minutes. We now have a series of presentations we are going to go through, and we're going to start off with an update related to legislative bills. And Nagla, I'll let you do that.
Thank you, Dr. Lakey.
I'm going to start out with talking about HB 18, starting out with the CPAN PeriPAN component of HB 18. We have gone live with providing both CPAN and PeriPAN for rural hospitals starting on May 2026. Additionally, we're looking at different ways to increase engagement activities for rural clinics. As you know, we had started with all clinics, including rural clinics, since the start of CPAN PeriPAN. But, we realized that we need to engage rural clinics and rural providers a little bit more. And so that's kind of some of the activities that we're doing at this time. We continue to look at the data and see how the effects of the initiation of the CPAN PeriPAN with a focus on rural hospitals and rural clinics is going. As far as TChat, TChat was determined to work through CPAN. CPAN would identify whether the consult that was provided should lead to a referral along with the provider or the hospital. And so we have determined that we want to start with a pilot phase. The pilot starts in September 1, 2026, and it's a 6-month duration. And the pilot is really more as a early implementers to determine what are things that should be improved in the process, and determining that, followed by a full implementation in March of 2027. So we have already held a webinar in May 2026. We started technology changes in the trait system, and we're expecting training to start in August of 2026. There was a survey that was sent out to all of our HRIs to determine who would like to participate in the pilot. Out of the 12 HRIs, we had 10 HRIs that said they would like to participate. And out of those, 9 of them would like to participate and offer TChat during that pilot phase to all rural hospitals and clinics in their areas. So switching to HB 6. HB 6, we have put in place the resource list that was identified that we should have on our webpage, and we update that version on a quarterly basis. Also, we put together a resource policy that Ashley presented at our last EC meeting and that we will be voting on today. Then switching to third-party reimbursement, we have a consultant that we have been working on with to collect data and to identify how to put this report together. He has been talking to all stakeholders, all HRIs, and in April of 2026, we had a meeting with HRIs to elicit additional input. And he continues to work on the report. We're adding additional data, and we should be having a draft report within the next couple of months. So this is the end of my presentation.
All right, any questions for Nagla? Hearing none, let's move forward and go to the budget updates. I'll turn this over to Alex. And as we begin, Alex, again, appreciate all the work you're doing right now, pulling together the budgets from the various institutions, organizing we average about just a little less than 2 hours per institution, sometimes a little bit shorter. I don't think any of it gone over that, but again, appreciate the institutions for your time as we go through and position us for the next year, but also think through how do we position the consortium for the next biennium. With that, Alex, let me turn it over to you.
Thanks, Dr. Lakey. And I do want to echo your sentiment. Thank you very much to all of our HRIs for participating in this process and providing such good feedback. I think the meetings have gone well. That being said, we still have a handful left. So we are in the process of rebudgeting for FY27, which is the second year of the current biennium. And that kind of sets the stage for your FY28-29 requests. And so, and Dr. Lakey will speak on this a little bit as well, but part of the budget process is submitting a formal budget to the legislature, which will occur this summer and probably occur within the next couple of weeks, where we won't have really finished our budget meetings, and we will still be having continuing conversations with everybody based on those budget meetings. Those of you who have already gone through your budget meetings know that you are working on those revisions right now, and that's something that we would want to incorporate into any requests that we send to the state. So with that in mind, we will have to today work on approving this process where we will go through with a budget request and come back to you after we've made that formal request, which will be based on what you have submitted to us so far, but with the opportunity, hopefully in the fall, especially as we have more conversations with the legislature and the folks downtown, that we can make refinements and revisions to that request after we have to actually formalize our request in the next couple of weeks. Any additional thoughts?
Any questions from anybody?
Alex, so the budget, which technically starts September 1st, right, for the next year.
And FY27, yeah.
Right, and so will we have a finalized budget by that time, or are we going to go into a period of early?
Finalized FY27 budget. And thank you, Charlie. I wasn't clear about that. So the request I'm speaking about is just for FY28-29.
Okay.
FY27, we can internally keep working on that and refine it. It's just more for this more formal request that we have to submit, which is called the Legislative Appropriations Request, the LAR. We do have to send that to THECB for them to incorporate into the entire big budget request. But as far as FY27 goes, we'll work with your revisions, and those will fall into whatever becomes your budget transfer for FY27.
Yeah, good point, Charlie. You know, again, the different in our mind between what we need to do next year and then the process of getting ready for the next legislative session. And, you know, getting ready for the next legislative session, there's things that are occurring early, before the next meeting we have, that we're going to need to be able to give the Higher Education Coordinating Board a preliminary budget that we'll massage later. In each of these meetings that we're having right now, part of what I have been telling institutions is I think we have to be very mindful going into this session related to a lot of the budgetary challenges I think Texas is going to have. At HHSC, I think there's going to be significant ask over there to just get through this biennium, not even the next biennium. I think tax revenue, oil and gas is doing well. Other parts of tax revenue are not. And so we're going to have to be careful, especially as the consortium has grown, to make sure that the ask is something that we can fully justify. And so in any of these meetings, have been asking people to be very careful to justify any increases. I'm trying to be very careful that we don't start new programs next year that would obligate the legislature to fund it. I think that's how you can get into trouble with the legislature, is to obligate the legislature for something that they haven't approved. And so we're having that discussion. That's the, again, this is quite a bit of work on our team. Again, 12 2-hour meetings and then putting that all together for a budget. And we will need to be able to work through a preliminary budget, go ahead and give it to the Higher Education Coordinating Board prior to our next meeting, but you'll have that conversation with us at the next meeting, kind of where we landed, and let us know where we maybe need to massage over the next several months before the legislative session actually occurs. Alex, did I get that right? Anything else I need? Yeah. The other thing that I've been telling folks is that carry forward has been really helpful to us this biennium. And our budget is a kind of three pots of money right now, with the 283 million from general revenue, ARPA dollars, which are going away, and then the carry forward. And so we will have to have this discussion on several parts. One, what ARPA projects has shown to be really successful, and we need to continue them. Perry Pan being one of the examples, but there's other ones too related to workforce. And so that'll be a decision that the legislature is going to say that, yes, we want to continue those, move them from ARPA to GR in the next biennium. But my other point was, carry forward has been very helpful. And so I think it may be helpful again. And so we've been telling folks, just because there's money there, if there isn't something the legislature has told us to do with those dollars, to be very careful and conservative of just using those dollars, because we may need to, and this is part of the trust, I think, that we've developed with the legislature, to say, if the legislature hasn't told us to do this, if it doesn't make sense related to the direction, we'll hand those dollars back and then ask for them to come back to us related for the next biennium. All right, Alex, anything else?
No.
All right, very good. And again, thank you. It is a ton of work, and I really appreciate you
So
putting that together.
Dr. Leakey, we will have to vote to approve that process.
Okay, but that'll be, you want to go ahead and have the vote right now? Okay.
Yes, sir.
All right. So is there a slide to lay that out, or is it just what I just said?
It's just what you just said.
Okay.
Yeah.
It's so the item on the table, we'll need to have a motion and a second, is for us to continue these, and it's for the next biennium, and not for fiscal year 27, but for the next biennium, for us to continue the meetings that we're having, to put together a budget for the next biennium based on that information and the ongoing discussion with the HRIs, and submit that to the Higher Education Coordinating Board prior to our next meeting. And so it won't have that formal approval from this executive committee, but you're allowing us to go ahead and move forward to meet those timelines, again, based on our best insight. So moved by Dr. Nemiroff. Is there a second?
Second.
Second by Dr. Ibrahim. Any further discussion?
Dr. Raji had his hand up.
Dr. Raji, did you have your hand up?
No, I was seconding.
Okay, very good. So I have a motion and a second. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye.
Opposed, nay. Anybody abstain? So let the record show that we had unanimous approval for us to move forward in the budgetary process, and then to bring that back at the next meeting after we have submitted it to the Higher Education Coordinating Board. All right. Lainey?
Lainey's virtual, but she's.
Okay, Lainey, let's go to you related to an update on communications.
Sure thing. Good morning, everybody. I just piggybacking off of the HB 18 mention that Nagla shared. We've created a few communications materials that are external facing. They live in SharePoint. There are some for CPAN Peripan, and there's also one for TChat, just to help support in the outreach efforts and engagement with rural clinics and hospitals. So those are available for teams to use. It helps just kind of on the TChat side explain what TChat is and what parents can expect from a potential referral. And then on the CPAN Peripan side, just really explains what CPAN Peripan is and how it can potentially work into a workflow. They're really just meant to help with that engagement and help create those relationships and sort of explain things to the new teams that we may be engaging with. The other thing I wanted to share today was just a reminder about our promotional items policy. So before teams submit items to me for review and to UTS to review, I just would really ask that teams review that policy. There's a lot of detail in there around sort of what you can order, when and how, and all of that stuff. And so I just would ask that teams do a review of that before submitting items. A few of the questions that have come my way are really answered in there, and would save you some of the work prior to, designing things or anything like that. But if there are any questions around the promo item policy, just feel free to shoot me an email. Always open to ideas and potential reiterations to that policy in the future. So just an open line of communication, I think, is absolutely best. And then lastly, I just wanted to thank everybody for their help with our anniversary. We had our 6th anniversary of CPAM in May, and we had some newsletter content. We had messaging that went out through our partners. We had some social media content, and we had a lot of amplification by our HRIs. So I just wanted to thank everybody and appreciate that. And it's always fun to celebrate. That's always a fun one, communications wise, to work on. So I just appreciate the help. And that's it from me today.
All right, very good. Any questions for Lainey? All right, hearing none. Thank you, Lainey.
Thank you.
Let's now go to the resource sharing policy, and I believe we have a vote on this one, right? Okay. One second, folks. We are working through a technical issue, and we will be sharing that policy in a second.
I can go ahead and start and just give a verbal update until we get the slides up. Good morning, everyone. I am going to overview the changes that were made to the resource sharing policy since our last EC meeting in preparation for our vote today. And so as a reminder, the resource sharing policy establishes guidelines for resource sharing through the centralized database utilized by TChat, CPAN, and Peripan teams to share mental health related resources with requesting providers and families. The policy covers the platform for sharing resources, the process for adding and vetting new resources, the verification process to follow when sharing resources out, and expected timelines. Slide, please. Since our last meeting, we made a few changes, including updating the language on the CPAN Peripan resource sharing template for any resources being shared that were unable to be re-verified. This updated language just indicates that the resource was initially reviewed, but not all office details were able to be verified before sharing. And additionally, an update was made to clarify that all resource sharing templates must be distributed securely and in compliance with HIPAA requirements. Thank you to the EC for your feedback on the policy. And once the policy is approved, it will be implemented. Are there any questions?
Any questions, anyone?
This is good.
All right,
Really the right thing.
all right. So Charlie, can I take that as a motion?
You can.
All right, very good. Do I have a second? Second from Luann Southern. Any further discussion? Hearing none, let me take the vote. All in favor of passing the resource sharing policy signify by saying aye.
Aye.
Opposed, nay? Did anybody abstain? Hearing none, let the record show that we had unanimous approval for the resource sharing policy. Let's now go to TChat policies. And again, we will have a vote on the referral policy. And Stephanie, let me turn it over to you.
Morning, everyone. So we'll start with the overview of the three policies, if that's okay. So we have three TCHAT policies that we're reviewing today. According to the consortium's policy governance, all policies are reviewed at least biannually. So these three policies were established in 2024. So we're just going through a round of reviews and updates to ensure the policies are aligned with current expectations and changes in the program since then. So starting with the next slide, with the school outreach and enrollment policy. So this policy covers the guidelines around how we conduct outreach to school districts and campuses and enroll them into TCHAT. It covers everything from the outreach process, requirements for MOUs with school districts, onboarding activities, our expectations around non-public school outreach, and exceptions to the on-campus model. Next slide. So the key changes we made to this policy we're broadening the definition of outreach to clarify that it's beyond just outreach directly to schools, but engagement can occur at local and regional events such as ESC meetings or community events. The background checks language we are incorporating from the fingerprint-based criminal history background check policy. We're archiving that policy and just incorporating the language into the school outreach policy. And that just aligns with the TEA guidance on contractors' background check requirements. We're adding language for TCHAT training presentations that should be approved by the UTS system. This is just aligning this process with our current consortium's communications policy. And we're clarifying expectations for the enrollment of private schools, which is still optional at the HRI's discretion, and homeschool students we're just encouraging. We get very few homeschool student referrals, but just noting the differentiation between homeschool students and private schools. And then lastly, we're clarifying expectations and allowances for off-campus TCHAT services. We know that there's a common barrier at schools for space and staffing constraints, so we just want to encourage HRIs to work with schools when they face these barriers to figure out off-campus alternatives, but the primary location for services continues to be on school campuses. And then, of course, we added language for 100% virtual campuses that have an exception for the on-campus model. Next slide.
Thanks.
Okay, the referrals and enrollment policy is the second one. This policy covers the steps of processing student referrals and enrolling them into care. So everything from who can submit a referral, the processing steps, expectations for intake appointments, and assessments that are required to send to the students and/or their parents and guardians. Next slide. The key changes that we're proposing for this policy, there's a proposed change around referrals over the summer break. I will go into this in more detail at the end of this overview. This is the point that we're hoping to bring for a vote today. So I'll skip it for now. We added language to note that the UT system and the medical director may allow referrals from different sources. This is just to accommodate the upcoming HB 18 changes, as Nagla had mentioned. Referral sources may shift as we expand to rural clinics and hospitals. We also have new language on archiving referrals, and we have added a list of the required assessments to be sent to families as part of their enrollment. Next slide. The final policy that we are revising is the services and discharge policy. So this policy covers the requirements around TCHAT service delivery. It covers a range of items as shown on the slide, including appointment standards, treatment approach for intermediate and bridge services, referrals to external providers, mental health education, and TCHAT training parameters. Slide. So there's a bit more changes or updates to this policy. First, we added overarching language to ensure that TCHAT just remains in adherence with legislative requirements. As these requirements may shift, we just want to ensure we all, as members of the consortium, remain in compliance. We also added language to note where requirements around parental consent and parental engagement may differ if the student is 18 years old or older. The same policy change I just mentioned on summer referrals is also mentioned in this policy, so I'll go into that in a minute. And we put into writing the requirements for discharging students from care. It's not a change in process, but just added in writing here. We added language as well for the PCR, the project change request process, and exclusions of what TCHAT does not cover. And then we clarified and updated the intermediate services expectations and criteria. We clarified bridge services expectations, added new language on referrals and Wellnitty, which is just aligning with the resource sharing policy that was just approved. And we clarified expectations around presentations for mental health education and those used for TCHAT training purposes. Lastly, we updated the definition of short-term services. Next slide. So you should have all received copies of the revised policies along with the feedback that we received from HRIs. Over the past several months, we've reviewed the policies and made updates in collaboration with the medical director, and then as well with the HRIs. They've provided their feedback and we've made some updates as well. So we're now introducing the policies to the executive committee for your feedback. And so I welcome you to send your feedback between now and the next meeting in August, and we will incorporate changes as appropriate and then vote at the next meeting. And if approved, they will be implemented in August. Are there any questions on these policies before we go into the summer piece? Okay. Next slide. Okay, the last point, this is a proposal for a policy change that came from a couple HRIs that submitted project change requests. The language proposes for the policies as written here. So during the summer break, HRIs may accept direct referrals from the parents and guardians of students of active TCHAT schools if the parents and guardians are unable to obtain a timely referral from their school liaison. And just as background, TCHAT offers services year-round, and so typically the referral pathway is that a designated school liaison, such as a school counselor, would submit the referral for TCHAT. And parents may ask the school counselors to submit referrals for their children, but during the summer season, when school is out, HRIs receive less referrals and school staffing footprint is typically leaner over the summer. So although schools maintain a designated liaison over the summer for TCHAT, because they have fewer staff, the schools may be harder to reach during this time. In this proposed process, families should still contact the school for a TCHAT referral over the summer, but if they're unable to reach them or get a timely response, this policy change would allow the parents and guardians to contact the HRI, and the HRI may submit the referral for the student on behalf of the school liaison. The goal is that the family can access care more quickly, and it would support the school staff over the summer if they're unable to refer the student in a timely manner. Are there any questions?
So if, like, let's say a parent would call TCHAT and say, you know, my son's enrolled, their school's enrolled in TCHAT, but I haven't been able to reach the school liaison. Does the HRI have to double back with the school to verify that the school was notified, or is it okay for the parent to just go ahead and refer directly?
I mean, I think those details we haven't discussed in that. I think it would be, and please correct me if you think I'm wrong. We can trust that the parent, we would confirm with the parent that they did reach out to the school.
Okay.
If the parent says, yes, I reached out to the school and I couldn't get a response, I think that's clear. If they said, no, I haven't tried, we would direct them to please try to contact the school.
Okay. Right.
So this is a grassroots effort that's being driven here because we've heard this
Yeah.
from a number of parents.
Yeah.
And schools vary on their responsiveness. And the fact is, we have capacity in the summer, right? And so we need to take advantage of that for the benefit of the kids.
Okay, great. And then, like, what would the time frame, like, date wise be? Like June 1 to August 1, or like, what are you thinking about time frame?
I think this is just, it's not a specific date, just knowing that schools may have different summer breaks. So it's just over the summer period. So it can be communicated to, you know, if a family reaches out at that point when they say the school's out, but, you know, I haven't been able to reach my counselor, then they try.
Okay. Thank you.
Dr. Wakefield, first we need to recognize she's here, and second, I believe she has a question.
Hi, thank you. I mostly just have a concern that I want to share that is long. I mean, I do think that you guys have added a few things to the policy based on that concern that I appreciate very much. I just do have a concern, one, that the schools won't be aware that they're referred, and two, that it will be hard to turn it off at the end of the summer. Like, how are parents being notified of this? What kind of outreach are we giving? And, you know, and at the end of the summer, we're going to have a bunch of parents doing, trying to refer in that way. And then we're saying, no, go back to the school. And so I'm just worried about the chaos and that kind of communication. And, think that we continue to get, referrals over the summer. I do think that it is harder for people to do that over the summer. And wonder if it would be better to work more diligently with the schools or the education service centers about communication related to how they refer than to changing the referral process, because I worry about the back and forth of the changing referral process and how we're going to help parents understand that change.
Yeah, thank you, Dr. Wakefield. I think we did try to adjust the language from what we had originally shared with the HRI based on concerns that you just shared, by maintaining that the parents should contact the schools first. We're hoping that we will maintain that is the still remains the primary avenue to get a referral, and it's only if a parent is has noted that they're unable to reach the school, or the referral still hasn't come through, then the HRI would be able to submit directly. But open if there's other.
The current process now is that is kind of what happens, that they can't get a hold of someone at the school because we know that the school is short-staffed. Then the parent can, like, they don't, if they can't get a hold of someone, the HRIs are expected to identify someone who will be at the school over the summer that they can contact. And if for some reason they can't get a hold of that person, or they're having a hard time, the HRI is able to help facilitate the referral. So that is what is supposed to happen right now. And they're not supposed to go back and forth, or it's not supposed to be super complicated. The way that it's written now is the HRI can facilitate the process. So that's what exists right now, just to make sure there's kind of clear understanding.
And then to your first point, Dr. Wakefield, about notifying the school of the referral, because we're accepting of active teach at schools as the referral, as if the HRI enters the referral into trait, the school will be able to see on their side the students at their school who have received referrals over the summer.
So it sounds like this will be something we implement but monitor, right? And so we're going to need to see how it plays out, understanding Dr. Wakefield's concerns, also understanding the gap that Dr. Nimroff is bringing up right now. But it seems like this is something then we're going to need to see how it goes this summer, monitor it, and then decide in the future how, if it needs to be stepped back. Lee Johnson, I see you have a hand.
Thank you, Dr. Lakey. I'm looking in the document, I'm looking at section 3.4.3 under bridge services. And I'm just curious, the first statement there, it kind of alludes to within a reasonable time frame. So like if an HRI is unable to be transferred, or a kid is unable to be transferred within a reasonable time frame, I'm just curious, what is the reasonable time frame? Is there some contemplation of that in another part of this or in some other policy we have?
The language previously, I think, said if they could not be immediately transferred, and we received feedback that seems too soon. So I think we would leave it to the HRIs to kind of, at their discretion, what they consider reasonable. That if there is a wait, I think we don't want to put a specific date or time period on that to let every HR kind of determine what they consider reasonable.
Yeah, I would suggest maybe there's some language that could be a little tighter there. I mean, I think reasonable time frame could mean very different things to very different organizations. That's just my comment. Thank you.
Okay, we can take that feedback and consider it for the round of revisions that we'll work on before August. Thank you.
And to be clear, Stephanie, for me, that the main thing we need to vote on right today is this language here, so that HRIs we've started summer already and be able to receive things. And then we can have further input related to all the other plans that the policies you had come next meeting, right? Mm-hmm. Very good. All right, Nathan Maxwell.
Yeah, just wanted to say on future planning, I think there's a willingness from the service centers So if there's personnel changes over the summer or there are, the inability to get a hold of school systems, service centers should have a little bit more continuity of service, over the summer months. And if we need to be that liaison, we have point of contacts there where we may be able to assist. So just in future planning, I think there's a willingness on our end.
Okay. Very good. Thank you. Any other comments? Okay, hearing none, we'll need to have a motion. And again, all we're approving is this phrase here that HRIs may accept direct referrals from parents and guardians of students of active TCHAT schools if the parents and guardians aren't able to obtain a timely referral from their school liaison. So that's the only part that we're going to approve. And then we'll continue to work on the other policies, bring them back to you for the next meeting. So with that, do I have a motion? Motion by Dr. Nemiroff. Do I have a second?
Second.
There are several seconds there. I'm not sure exactly who that was. Dr. Wagner, is that Dr. Wagner?
That's me, yeah.
Okay. All right. Very good. Any further conversation? All right. Hearing none, all in favor, signify by saying aye.
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 Opposed, nay. Did anybody abstain? Hearing none, let the record show that this verbiage we see on the screen has been approved. And again, the other policies will be brought forth to this group at the next executive committee meeting. Thank you, Stephanie. Let's move forward next to
Dr. Plisk, are you presenting?
Are you? I know you had a conflict in. Yeah.
That's good. Yeah.
So let's move forward and let's go to Perry Pan. Dr. Wakefield, let's have an update from you on Perry Pan. Dr. Wakefield, if you're there, I can't hear you.
She's on mute.
Dr. Wakefield, we cannot hear you right now. We can hear you earlier.
Yes, sorry, I am here.
All right, very good. All right, let me turn it over to you.
Okay. All right, let's get started. Perry Pan, next slide. Great. So we, these are our enrollment over time. We wanted to show this slide just so that we can show that we're continuing to increase enrollment of our obstetric and gynecology colleagues. This is really, we have more enrollment than this when we think about our pediatricians and our family medicine doctors and nurse practitioners and PAs and nurse midwives, but really we're following this metric uniquely for Peri-Pan for our OB-GYN colleagues. And we continue to show increased enrollment, something that all of our teams continue to focus on over time. Next slide. Our consultation volume also continues to increase, which we're really excited about. You can see that in March we had a record volume, but in April, even though it fell a little bit, we still had a record volume for the year other than this very high March number and very close to one of our highest. I won't share our May numbers because they're not on here and I don't want to misspeak, but we're really excited about our May numbers. So overall, continued to see this increased trend over time of our total consultations month over month, and year over year, kind of seeing this trajectory up and down. We don't see the cadence that we see with children where we see an, rapid increase as the school year comes and then decline in the summertime. But we are kind of seeing an increase, we're trying to look at what those changes look like over time, and we haven't seen a distinct pattern so far. So we're really excited to continue to see increased consultations over time. Next slide. This slide just shows what percentage of our calls our psychiatry is involved in. So this is the percentage of calls that go to the reproductive psychiatrist. Of course, our behavioral health clinicians answer the phone, answer many questions, help find resources, referrals, give some guidance. But this is the number of calls that we see or that they perceive need to go to the reproductive psychiatrist to ask to really look more at diagnostic clarification, medication questions, and those sorts of things. So we're still seeing a very high percentage. Many call lines across the country are really seeing, two-thirds staying with the behavioral health clinician, 1/3 going to the psychiatrist. We know that the more that the psychiatrist, the more that are linked with that psychiatrist, the more likely practice change on the front lines is happening. So that's why we're tracking this metric. We continue to be really excited about more than half of our calls are going to the psychiatrist. Because like I said, we in looking at the data from other programs and nationally, that this seems to be what drives that practice change behavior on the front lines. And so we're really excited to see this. Next slide. These are our direct consultations, and these happen once the call gets to the reproductive psychiatrist. If the assessment is that there needs to be more direct or diagnostic clarification, or we're unable to make a recommendation without seeing the patient, or we make a better recommendation if we could see the patient, or that frontline clinician is feeling uncomfortable with any part of the recommendation and would like us to see the patient to increase their comfort level, this is when we do a direct patient consultation. And so we started this back in January of 24, and you have seen that these have grown over time, sometimes dipping down, but we are having quite a few. We have many of our HRIs online. At the very beginning, we had one HRI doing direct patient consultations, then more came online. Wherever the call is received, from whatever HRI the call is received, even if they are not doing direct patient consultations at the HRI site, we can do a direct consultation for that patient through the network, through our network of HRI. So we can provide the service no matter from where the call comes. And you see that we are all working very well together to get these done and have in the last few months some of the highest direct patient consultations that we have seen. Next slide. So this is a very busy slide. They kept us to a slide number limit. So I'm going to just tell you kind of overarching what this slide is about. This is about our Pathways implementation. So to remind anybody, or for those of you who haven't heard about our Pathways implementation, this is from a PCORI project that we are working with nationally with Lifeline for Moms. This is about implementing practice changes within the obstetric practice to improve the flow of screening and knowing what to do if you have a positive screen for depression or anxiety, and knowing when to call peri-pan. So really trying to utilize practice management, practice changes for both increased screening, which is already standard of care, but often doesn't happen or doesn't happen in a methodical way. Or if a positive screen happens, people aren't sure what to do next. And so really implementing standard of care screening and then reflex call to peri-pan for a positive screen so that we can help with those next steps if needed. If the clinician already knows what to do with the positive screen, there's no mandatory call to peri-pan, but to know that we exist as a resource in that case. So we have 3 active clinics in Texas in the implementation phase. And additional clinics in scheduling phase, really thinking about when they're going to, setting up the cadence of these meetings. We have a Texas clinic that will be the first practice nationally to launch the finalized Pathways implementation plan. So we're really excited about that. It's a highly engaged practice and really, motivated to implement these screening procedures and following through. And we've already seen some increased call volume from this region. Some of the things that we found that we think are really helpful in future planning for peri-pan and for CPAN, just thinking about these access projects and how to be most helpful to our clinics around the state. is that the practices were really excited and highly valued clear post-screening workflows, what to do after a positive screen, saying, here's who you call, here's what you do, because just having a standard practice or, you know, a professional organization saying this is a standard to screen really didn't come with a lot of guidance on what to do with a positive screen. And so this project, the Pathways Project, is helping those practices understand with a positive screen exactly what is your next workflow. We have also seen that PeriPan integration is increasing clinic engagement and consultation utilization. So when when they know what to do with a positive screen, they call us, we work together. We wanted to just show a few things, a few quotes that we had from this process, because it's been pretty lovely to see this. This process helped us build a workflow that fits our practice and finally gives us clear next steps after screening with PeriPan integrated into the process. So that was really exciting to hear. The collaboration fostered stronger working relationships with clinics in our catchment area and increased engagement with PeriPan services. The process highlighted the importance of developing workflows collaboratively with practices and reinforced that there are no shortcuts to sustainable implementation. I think, we hear from teams all the time that we've gone to talk to a clinic, they know about us, but then we don't hear from them. And so this process has really helped our PeriPan teams understand how to better integrate with a clinic and remind them that they're there, kind of be that lighthouse, that we're here when you need us, that we want to be for our obstetric clinics across the state. I'll let you read the rest of these quotes, but wanted to provide the slide just as an overview about the process and the progress with this Pathways implementation project. I think that's the last slide, but next slide, and I'll be happy to answer any questions.
Very good. Thank you, Dr. Wakefield. I was doing some quick math here related to the number of OB/GYNs practicing in Texas and the number that seem to be enrolled. And it looks like you're about 1/3 of all the OB/GYNs in Texas now enrolled into PeriPan, which is good. Kind of yeah.
It is good. We're not satisfied with that number yet, so we'll continue to work towards a higher percentage. But we are really excited, and our teams do continue in their attempts to engage our obstetric colleagues. And I will say that some of the, it's interesting to have the list of the obstetricians and then to contact those obstetricians. Some of them are working as hospitalists. Some of them are working in different capacities that would not typically utilize PeriPan. And so that denominator is a little bit different for us than the overall total number of obstetricians. But we are excited about our progress and enrollment, and we'll continue to work towards even higher enrollment over the next few months.
Very good. Any other questions, comments? Hearing none, again, thank you. And we are going to transition to the COSH and CPAN program update. And Edith, I think you're going to give that today.
Yes. Did you say me, or did you say someone else?
I said Edith.
Oh, okay.
But I think Dr. Wakefield, we agreed you would go ahead and take that. Thank you.
All right.
Yes.
All right, go ahead. Okay.
I think I am. Sorry. I was like, okay, did we make a change? That's totally fine. Yeah, you get more of me for a couple more minutes. You can see of our CPAN consultations, we continue to see increases year after year, similar to that of PeriPan. You see that there is somewhat of a cadence here that we can see that follows what we see for children in our outpatient clinics as well. So in the summertime, there is some easing up of presentation for symptoms. And then as the school year starts, we see an increase. So that is every child psychiatrist, every child mental health clinician knows this cadence. Our highest referrals sometimes are right around testing time for schools. So we continue to see that over in the first grading period. So those are typical things that we know as child mental health clinicians, and CPAN cadence seems to follow that. But we're excited that our consults over time continue to increase. And you see April with 1989, our highest month ever. So we're very excited about that. Next slide. So here's our consult volume. You see that April has been, I just said that with the 1989 has increased. You see this year over year increase from 25 to 26. And our enrollment, this enrollment encompasses all of our clinicians and clinics. And to date, in the CPAN consult activity, over 70,000 completed consults, which is really amazing. And thinking about the impact of how many clinicians we've supported in those consults and how many patients we've supported their care in those consults. And then thinking even beyond the consult, that with every consult, we are imparting some clinical information to that frontline clinicians that they can be helped. Even an additional patient can be helped. So the impact really is far reaching here. We continue to have a very, very short response time. You see this less than 3 minutes average response time, and 99.3% responded to within the 30 minutes. Next slide. On provider consultations, you see a few more of these. This is probably closer to the national standard or the national what we see national average. Where we have 2/3 of our calls really being handled by our non-psychiatry colleagues within the line, and a little more than 1/3 handled by our psychiatrists. So we continue to watch these numbers, monitor these numbers, encourage our teams to involve the psychiatrist, the child psychiatrist whenever appropriate. But we are happy with these numbers as these really reflect national averages as well. Next slide. These are direct patient consults by month. Again, you see from February 24, we are increasing over time with our highest number of direct patient consults ever in April at 152. You think about that as a lot of children seen for a direct consult, a diagnostic clarification, medication recommendations, other therapy recommendations, some education to parents and families, and then even allowing us to provide better education back to that clinician about what we're seeing. So a lot of work being done there by our teams. Next slide. So projects coming up, provider portal launch in July. This has been a long awaited thing for all of us, our project for all of us. We're very excited about it. This will allow our clinicians to enter a consult into a provider portal so that they can utilize whatever mechanism is most efficient and effective for them, whether calling or providing that consult into the portal by typing it. They are having their clinical assistant typing it for them. We will still have the same metrics for this project or for the provider portal, where we'll try to get back to them. Our metrics are the same, getting back to them within 5 minutes, and a psychiatrist within 30. We still will have that phone call follow-up. This is not an asynchronous consultation line where we'll be consulting back by typing. We still will follow that call process. But this is another way for them to request a consult. We're also really excited that this will be a mechanism for us to send screeners and referral resources so that they'll have them in front of them in the portal and not have to remember where they are or sending them via fax and go find them off the fax machine, and they can refer back to them in the future. Prior to release, we have been meeting with teams to review the rollout plan, providing materials to team members, guides, frequently asked questions, flyers, scripts, all of those things. And we will continue to offer considerable support and office hours during the launch. Next slide. That's it. So happy to answer any questions about provider portal or other things for the CPAN and COSH update.
Any questions? All right. Hearing none, let's transition to the COSH and TChat program update. And I have Jen Cole giving the update. Sarah, I don't know if you also have a part in this, but I'm going to.
No, it's Jen. Jen's got this one.
No,
All
I'm
right.
going to do this one.
All right, very good.
I will do my best Dr. Williams impersonation.
Okay.
All right, so this is our usual T-Chat referrals. We are very excited because we are just shy of 135,000 referrals in T-Chat. The exact numbers at the bottom, 134,902. We're starting to slow down a little bit, which is kind of nice because we had a lot of great startup growth. And we're getting close to the end of the year, so we're doing our usual curve for our referrals. Next slide. We're also seeing really great enrollment. So we're not only getting good referrals, but we're actually enrolling the students that we're seeing. So again, that's really nice. We're managing to really get engaged with our families. Our teams are doing a great job of getting in touch with them, getting paperwork completed. We've really seen a great uptick in our measurement-based care. So when our families reach out, they're completing assessments, which are giving our clinicians great opportunities to really see what's going on with them, get measurements that are really giving good insight so the clinicians can really do great work with them since we are brief and we don't see them. This really helps give them a great plan for their care. So again, this is just insight into our enrollment for our families. Next slide. This slide shows number of treatment sessions and students served. So the red line that kind of goes through the middle, that's our number of students that we serve. And then the blue bars are the number of sessions that are provided. And so this actually is covering all of our sessions. So our therapists, our social workers, our psychiatrists, our case managers. So those are all of the sessions that are provided. This is our usual stuff. And then this kind of just goes over all of the different projects and things that are going on. We are really excited. We've been working with our presentation work groups. So we've been working in collaboration with the Center for Healthcare Communications and our different areas of expertise with our work groups. And so we're getting ready to present our anxiety decks for our counselors, our parents, and we'll be actually getting ready to share those. We've got our substance use ones that are finishing up and then our trauma work groups. So we have those are about ready to share. We've been doing a lot of work with HB 18 implementation and trait and making sure that in September, the referral process is going to be really smooth. That's been our biggest trait project that we've been working on. We're also on the trait front. We've been working on assessment emails, working on the communication that goes out and some automation that we've been working on. So that project is about ready to be released. We've been working with UT Systems to plan the TChat Summit. We're really excited about this. This is a great opportunity. All of our HRIs are going to come together. We've got a lot of great work sessions planned so the teams can really come together, look at our processes, look at areas for improvement, efficiency, different things that we can do. We're using a lot of the data for the teams to come together. We're doing this at the start of the summer so that they can use that time over the summer and really get things ready for the school year when they come back. It seems like the summer is getting shorter and shorter. Every year, we're already getting back to school requests for mid-July, back to school events. And so teams are already starting to get ready for all of those different things. So it's crazy. It's fun though. Walnetti has been a big thing for us in TChat. This is the first year that we've really been going strong with Walnetti. So we've been really working with collaborating with the HRIs to make sure that the training is very strong. They're really incorporating it in their process. It's a little bit different for us in terms of how we communicate with families. So making sure that the HIPAA compliance is there, the communication is there, the resources that we're using are incorporated into Walnetti. They're making sure that they're getting verified and that all of that communication is really strong and that all the teams are really clear on how to use it and they're incorporating that into their processes. So that's been a really big project that we've been working on. And then with the updates to the process and the policy, we've been working with teams to make sure that that's been incorporated really smoothly. And then continuing to meet with our teams and look at how they can improve their templates and make sure that they're working with families to make sure that as we get those increase in referrals and that increase in enrollment, that they can get the families in efficiently and in time slots that work for families and work with the schools, especially changes in the schools and in the staffing so that we're really collaborating with the schools to make sure the appointments are available, the space is available, and that as different things come up with changes in the schools, that we're able to partner with schools to make sure that we can get those appointments and make sure that kiddos are seen as efficiently and effectively as possible. And that as there are changes in staffing with HRIs, that we can work with them to make sure that that's as smooth as possible. And so I think that's our quick, efficient update. Any questions, anything we can answer on the TChat side?
Any questions, anyone? Hearing none, thank you, Jen. Appreciate all the work, and we will transition into the governor's report update. And Stephanie, I think that's you.
Thank you. Okay, on this first slide, this data is as of the end of May. So the Teach Up program was active in 7,564 schools, covering 84% of the student population. We had 4 HRIs that had increases in the number of active campuses this month. Next slide. We had 347 schools with onboarding status, and 309 of those schools had planned implementation dates. Next slide. This shows the MOU status for school districts by ESC region. So we had 2 ESC regions that saw increases in active TCHAT districts in May. Slide. This just shows the growth over time. So we continue to see a trend of upward growth in the student population and in the schools covered by TCHAT, though as expected, the growth has slowed as the years go on. Next slide. And lastly, this slide shows the reasons that districts have declined TCHAT services, and the top reason has been and continues to remain that the school or district may already have existing mental health services. That's it for me. Any questions?
A couple quick comments. Again, thank you, Stephanie. Related to the entities that have declined, and we're having this discussion in the budget meetings, but then again, just would remind our chairs that as we complete our budget, one of the things that we're going to need to have pretty firm input on is some of the ISDs that have been funded by ARPA for the mental health services, and ARPA going away, and expectation of whether they will be now expecting us to include them into TCHAT. And so again, would encourage all the HRIs to get as hard data as possible related to the plans of the HRIs that have so far not been included. Again, we don't want to exclude any of them if they want to be in, but we need to make sure we understand that before the budget is set for TCHAT. And then the other quick comment is there will be a legislative hearing, I think on July 7th, that we've been invited to. And I think most of it will be on TCHAT. And so we'll just ask people if as we get put together our presentation, we may have questions we need to get quick feedback on so that we can move forward. Dr. Martinez, I thank you for joining us. Is there anybody else that has joined us since we began our meeting that hasn't been recognized for the record?
He has his hand.
Oh, okay. Octavio?
Yeah, thank you, David. Sorry, I was a little bit late to the HOG meeting. Quick question though, is there any region of Texas that seems to be lagging behind in penetration of enrolling ISDs?
So, and Stephanie, you can jump in, but I don't really think so. We put up the map that has the state of Texas, and there's a few of these counties that are very small that aren't colored in yet, but there are some big ISDs that have had mental health services through ARPA, and many of the time it's some of the largest ISDs in which our institutions are based. And so those are the ones, and I guess the other part of that, Octavio, is sometimes they're not all out. They have a few schools that are in, but not the majority of them. And so that's part of the clarity we need as we put the budget together. So Stephanie, did I get that right, or anything you want to add? Okay, very good.
Yeah, David, my thought was any of our Texas legislators who may question maybe their own region and how the Texas Mental Health Child Consortium is working for them, just to be sure that we have it covered.
Yeah, the map is almost fully colored in, except for some rural areas that there are large ranches sometimes instead of really being population centers. It really is statewide, again, with different utilizations in different parts of the state.
Got it. Thank you.
Mm-hmm. Any other comments or questions? Okay. So then I'm going to transition back up to the top on the workforce update, and Dr. Pliska, go to you.
Right, I'll wait for the slide to come up. This will be a quick report, a one-slide report, in fact. 2 slides if you include the title slide.
Yeah.
All right. Later to, in fact, coming up, we will have reports from internal evaluation on performance measures. So I'll not cover that here. One of the big issues that we're looking at, we want to really document how much patient care is delivered through the CPWE program. And this has turned out to be a little bit more of a complex issue than we originally thought. Not to get into too much detail, but there is a statewide report from all of the LMHAs, which is referred to as EMBO. And the LMHAs have been reporting in centrally, and we've been looking at that report. We discovered that not all patient care activity of LMHAs is in that report for reasons I won't go into. In all of our programs, we get a lot of resident turnover, and sometimes the newly rotated residents are not captures. When HRIs share an LMHA, one HRI has residents in Clinic A, and the other HRI has them in Clinic B. The EMBO report aggregates them in a way that's, that potentially double counts. Or rather, actually, it's single counts, and it doesn't give complete credit to both HRIs. So we're really, a big project going forward here over the summer is to kind of work with everybody, HHSC, the local LMHAs, and the HRIs on developing a new report, because we want our patient care activity and number of unique patients served to be as accurate as we possibly can. And that will involve really a multi-tiered process that we're working on right now. The next thing is, of course, all the HRIs will be starting new rotations next month. So they're being asked to update their overall reports on the nature of the rotations. And then as medical director, I'm going to be initiating one-on-one HRI meetings analogous to those that CPWE and TCHAT hold in order to kind of really start to drill down on some individual issues at each HRI and determine, what issues there are in commonality that we can kind of continue to resolve any systematic difficulties that might be emerging. And all the rest of the metric development, I'll defer to the evaluations coming up.
All right. Very good. Any questions for Dr. Pliska? Hearing none, let's go to the CAP and the other workforce expansion program update. And Claire, I think you're going to do that today, right?
Yes. I am going to be doing this on behalf of Dr. Brenner. So for CAP, a couple of updates for our Texas Medical Schools Collaborative event. That is proposed to be scheduled for August 25th from 6 to 7:15 Central Time. And as a reminder, this is going to be a virtual workshop on the introduction of child and adolescent psychiatry. And it's intended for all Texas medical students within CAP programs. And it's to introduce medical students to this as a career path. So really trying to recruit them into that pipeline. There's also an update on the shared CAP didactics. There is a schedule set for our quarterly meetings. So our first one is going to be Friday, August 7th. This is going to be on the CAP and law. Tuesday, November 17th will be on eating disorders in children and adolescents. Tuesday, February 9th, 2027 will be addiction in child and adolescent psychiatry. And then Friday, April 16th, 2027 will be technology use and youth mental health. And as a reminder, this shared CAP didactics is for all CAP fellows in Texas, and this is intended to be a platform for cooperative learning across all of our HRIs with CAP programs. And then we also have the disaster psychiatry didactics. This is scheduled to be offered coming up here this summer. The dates that this will be available is going to be Tuesday, August 11th from 3 to 5 p.m., Friday, August 21st from 11 a.m. to 1 p.m., Thursday, August 27th from 12 p.m. to 2 p.m., and then Tuesday, September 15th from 8 a.m. to 10 a.m. And this one is a statewide educational opportunity for psychiatry trainees in all training levels and all subspecialties to equip them with knowledge and resources needed to serve their communities effectively during a disaster crisis. And then for OWE, we have concluded our initial meetings with the other workforce programs. We continue to have our quarterly affinity groups based on discipline being trained. And so for right now, we are focusing on the clinician groups of professional counselors, social workers, psychologists, and advanced practice providers. And those are my updates.
Very good. Any questions? Hearing none, Dr. Plitzka, we're going to go back to you related to Dissemination and Publication Committee's update.
All right, so what you see in the slide here is the DDPC approval since February 26. Some work of the external evaluation team on mapping processes for CPAN and TCHAT they were approved to submit an abstract to meeting. Dr. Kevin Wagner was approved to submit a manuscript on using exposure-based CBT within the TCHAT program. He'll report back to the DDPC with the journal review comments and any revisions that are needed. Dr. Sean Mitchell's project at Texas Tech Lubbock, that manuscript was also approved, looking at differences in rural versus non-rural pediatric health providers' views on dealing with suicidal ideation. We are Drs. Wagner and Sobczak both had projects approved. Dr. Sobczak's is funded by the NICMER project that we'll hear more about later. And then Dr. Shauna Clark joined the group representing our rural institutions. And so the process for the DDPC has been worked out. We're continuing to refine both the procedures and some of the policies to make it clear to all potential investigators about what they need to do and when they need to do it. And we may be bringing some of that information back to the EC at the next meeting.
Very good. We have a question for Dr. Nimro.
As you know, part of CTRN is the use of trauma-focused CBT, which has now been adopted by all of the HRIs. And understanding the Kevin Wagner paper that you mentioned, what is the overlap in terms of exposure therapy? Is he talking about trauma-focused CBT, which is part of the consortium? And we have 2 manuscripts actually on trauma-focused CBT, or is this outside of the trauma network? And
it is outside the trauma network. I think his work preceded the CTRN, initiating your particular program. And I think this is broader than just trauma. I think that this looked at other aspects of anxiety. So I don't think there's going to be much of an overlap.
I think the obvious question is how is exposure therapy defined? What was the fidelity of the treatments? I mean, if this is coming out of the consortium, we need to understand the number of practitioners, the fidelity of the treatments, the iterated reliability. I mean, these are important questions, right?
The committee looks at exactly those issues and determined that the paper was worthy of submission. I don't recall all the details right now, but I'll be glad to send you a copy.
Perhaps This could be shared with Cody Dodd, who leads the trauma-focused CBT effort for the
Sure,
consortium.
no problem.
Oh, thank you.
Any other questions, comments? All right, hearing none. Dr. Savas, let's go to you for the external evaluation update on the logic model for CPW.
Thanks. Yep. So I'm presenting the schematic of the logic model that helps us guide the evaluation planning for the CPW program. And I'll just walk you through it and explain why we're doing some of these things as we go. So the inputs column from the left to the right are the resources and funding and partners that are essential to the implementation of the program. So these things, these are the essentials, not all of the resources and guides listed, but overarching. And leading from that, with these resources in mind, we expect the following activities, which are the core components, to be implemented. And this logic model was also developed with key players, Dr. Plitzka, the UT system leadership, and internal evaluation team also, with HRI CPW leads giving us feedback and input along the way. So out of all of these meetings and feedback, we identified these activities. You can see listed. The HRI CPW lead participates in CPW leadership calls, review existing training sites and rotations for capacity to support psychiatry residents in public sector community mental health settings, establish partnerships between the HRIs and LMHAs or other community mental health clinics for resident training, maintain partnerships between the HRIs and LMHAs or other community mental health clinics for resident training, coordinate and administer CPW supported residency rotations, and residents are placed in public sector community mental health rotations to provide clinical services. Again, these are just core components, not every step. These activities then inform outputs, which inform the process evaluation or quality monitoring. And again, these are not all the metrics, but if these activities happen, we would expect to be able to identify it through monitoring these metrics. So number of community clinic partnerships, number of CPW leadership calls, number of CPW leadership calls with HRI CPW lead in attendance, LMHA, HRI community mental health clinics and resident satisfaction with coordination, number of community residents and faculty on CPW rotations, full-time effort of residents and faculty on CPW rotations, number of patient care visits performed by CPW residents and faculty, number of unique patients seen by CPW residents and faculty, number of patients seen by CPW residents who are children or youth, documentation of where graduates practice after completion. This metric crosses a little bit in not just program implementation, but informs evaluation, but it's an important step so we can identify people, how to contact people for future assessments. So if these activities are implemented as planned, we would expect these as a short-term outcomes. So short-term outcomes inform measures that you'll hear about later. It's overarching constructs. Not every single measure will have a short-term outcome identified, but these are some of the essentials. That we would expect, if the activities happen, that there's an increase in HRI and LMHA satisfaction in collaborating and coordinating on residency rotations. Increase in trainee delivery of public sector psychiatry care during the residency training. Increase in positive attitudes towards community psychiatry among residents. Increase in residents' knowledge of non-medical drivers of health and how they influence mental health. Increase in residents' knowledge of systems of care. Increase residents' intentions of practice, community psychiatry in Texas with children and adolescents. So these are, again, constructs that inform measures that inform our evaluation plan for the outcome evaluation. If these short-term outcomes happen, we would expect them to influence and result in the following intermediate outcomes. These are more these intermediate are measurable in a reasonable timeline, 6 months to a year. Follow-up, increase in collaboration between HRIs and LMHAs, community clinics on quality improvement. Increase community psychiatry resident training capacity across Texas. Increase in graduates remaining in Texas after residency training. Increase graduates entering the public mental health force. Increase in graduates practicing with children and adolescents. Increase in clinic service capacity for children and adolescents through residency faculty involvement. And then long-term outcomes are the result. If these intermediate outcomes happen, we would expect the following in the long term. So number of psychiatrists practicing in public or private nonprofit community psychiatry in Texas, increase in long-term access of psychiatric care for underfunded and seriously mental ill persons across the state, strong and stable psychiatric workforce pipeline, and increase in statewide public mental health system capacities. So overall, this is the schematic for the logic of the program, and good segue into the internal evaluation team's measures. And we work very closely together so that these all align. And I'm open to any questions or comments.
Very good. Any questions or comments? Anybody? Well, thank you for all the work to put that together, to you and your team. And I think it's does a good job outlining the work that we do under CPWE and how we can develop measurements. But again, if anybody has any feedback, please let us know. But that's the framework that we're using right now. Thank you. And let's then go to Molly related to the CPAN, PeriPAN, and TChat update measures.
All right. Thank you all. And thank you, Dr. Savas, for that nice transition. You all may remember that in the last fiscal year, we instituted some new processes to help provide additional data visibility to the HRIs, to leadership and their teams. And within this, we rolled out performance and observational measures for TChat, CPAN, and PeriPAN. And this year, we're going to plan to include CPWE and CAP Fellowship as well. So I'm going to start with those today, I think. Okay, great. So I'm going to present some draft performance measures for each of these programs, starting with CPWE and CAP Fellowship. But first, I want to take just a few minutes to level set on kind of what we hope for with these measures, what they are, and really kind of what they're not. So if you go to, thank you. Here's some of our definitions. We have two measure types, performance measures and observational measures. So performance measures are intended fully to help HRIs regularly assess their own performance and then use these measures to help guide quality improvement to reach its targets. We aim here for measures that across the consortium, HRIs and project leaders feel these are areas where we can continue to strive to kind of reach our excellence in quality. The targets that we set for performance measures are local to each HRI, and they are based fully on kind of historical performance, the context within HRI. We recognize that HRIs are staffed differently, their regions are different, and the needs are different. So we want these performance measures to really reflect the context that each HRI is within. And then our goal is really to kind of continue to drive that overall state improvement by having these like realistic, attainable targets that HRIs can work towards. So when we look for performance measures, we're really looking for things that HRIs have some control over, that they can make some changes and see relatively brief, over a relatively short period of time, some of those improvements. So as you think about the logic model that was just shown, although what we are looking for are those intermediate and long-term outcomes, what we measure in the performance targets are those more direct outputs and quality measures. In addition to those performance measures, we also have observational measures. And again, the goal here is just to provide more data to teams to help guide their overall ability to kind of understand how their team is doing across different areas. They are only seeing, each HRI is only seeing their own observational measures, but they do have some insight into how that compares to the HRIs overall by being able to see kind of where they fit in certain quartiles. And so any HRI is likely to kind of say this observational measure is important to us. We want to work and focus here as well. But there isn't any sort of overall state target for those. They can kind of work and see improvement, hopefully over time, based on what they've decided to focus in on. So that's kind of across all of the different programs, how we think about these two different kinds of measures. And then I'm going to share the performance measures that we have drafted for each one going forward. Next slide is sort of the timeline for this. The performance measures as well as the observational measures have been shared with HRI teams for CPW and CAP Fellowship. That was in May. And we sought input from the teams for these measures. And we're bringing them here to the executive committee as well as drafts to seek additional feedback. We'll be making adjustments to these based on the feedback, and then the measures will come back to the executive committee for a vote in August. Then in September, we'll be updating those performance dashboards to include the new performance measures or any changes to performance measures that have been made, as well as additional observational measures. Next slide. So starting with CPW, here are the proposed performance measures for this program. The first one is around educational experience of the resident. And we look to measure this across the fiscal year as a cumulative measure to identify the proportion of residents who have reflected that the rotation provides them with an excellent educational opportunity. And this is one of the things that we measure within the rotation survey that's conducted at the end of each rotation for those residents. The next metric is increased understanding of community psychiatry. Again, this comes from the resident rotation survey, and it reflects that the individual indicates that the rotation increased their understanding of community psychiatry as a part of that experience. We also look to, as Dr. Savas presented, attendance and involvement in CPW leadership calls is a part of the program. And so we look to see that HRIs are actively attending those collaborative meetings. And then finally, we look to see if the work is involving increased access to CPW affiliated providers for children and adolescents between 0 and 20, or to perinatal adults as a part of that program as well. So those are our 4 proposed performance metrics for CPW. And then I'll go ahead and share CAP Fellowship, and then we can pause for any questions. So we have a pretty simple one item CAP Fellowship proposed metric that involves participation of the leadership within HRI lead calls, as is consistent across all of the performances. So that one's pretty easy. I'll take a moment, because I'm sure once we switch into CPAN, PeriPan, and TChat, you'll forget all of these. So in case there's any questions right now, we can pause.
Any questions or comments? Hearing none, why don't we go ahead and—
David, I've got one.
Oh, okay.
I think, Molly, from the feedback we got from HRIs, there was concern that assessing the quality of the educational experience based on the resident's opinion alone, what might be problematic, although someone should tell the ACGME that. which it has some validity. I think we had talked possibly about adding a survey of the faculty in terms of what they thought the quality of the, are we going to try to move forward with that?
I think we are definitely going to try and move forward with that. Whether or not that can be a performance measure kind of right away, we probably need to get a little experience with that survey to understand that. But we can certainly provide that information back to the HRIs for observation. Okay. Well, let's talk a little bit about CPAN, PeriPAN, and TChat then. I will not repeat, but we do have the same sort of general definitions here about how we think about performance and observational measures, as well as a similar timeline because there's 3 programs. We kind of started this in April, but we will again bring this back in August for an actual vote. Okay. So I did include both CPAN and PeriPAN for the most part on the same slides just to save us a little time, but I will note where there's some differences. Okay, so starting off, most of these performance measures are the same performance measures we've had over the current year. And so I will let you know when there's a new measure that is different from what teams are used to at this point. So we start off with new caller satisfaction, and this comes from a satisfaction measure we do at the end of the first calls that providers make based on the question, how likely they are to recommend CPAN or PeriPAN to their colleagues. And we are getting ready to do some adjustments to how these surveys happen, and they will be embedded into the trait process. So we're hoping that that's going to actually provide some increases in our response rates to these surveys across the programs. In addition, there is another question that is a part of that survey that asks for, consult satisfaction is actually the same measure, I should say, but tied to individuals who are not a first-time caller. We are not currently doing this, but with the new changes in trait that we are hoping will go live in the fall, there will be an ability to ask not first-time callers, but subsequent callers, but no more than once every 6 months to limit burden on them. But then we will have some greater insight into the satisfaction of those multiple time callers. I think that will be an exciting addition. And then the third question has to do with how comfortable the provider is in applying the recommendations that were made during the consultation as well. So those are all existing measures. Go to the next slide. We are also looking at the proportion of PCPs, primary care providers, enrolled in CPAN. This will be a new measure, although one we've been talking about for quite a while, so not really new to the teams, but just will have greater ability to actually measure this. And this will be based on the percent of primary care providers who are currently enrolled in CPAN. And then our denominator is our best estimate of the primary care physicians assigned within the HRI region. And HRI teams have the opportunity to, when they contact those primary care providers, determine whether or not they are a part of the eligibility. And some of the reasons they may not be eligible is that they don't serve children, is certainly something. They work in a hospital, they're retired, they don't work in Texas. All of those kind of situations show up in our medical board lists. And so HRIs do some cleaning of that data to give us a better understanding of what the actual estimate of primary care providers who would be appropriate for CPAN are. And then the similar measure for PeriPAN is focused in on OBGYNs and those physicians. And again, the number will be those who are currently enrolled in PeriPAN, and then we'll have that estimate of appropriate, I have a typo there, appropriate OBGYNs who are assigned to that HRI region. And then the final measure going across both CPAN and PeriPAN is the percent of program leadership for those access programs participating in monthly leadership calls. All right, so the only new measures here are those proportions of primary care providers and OBGYNs for PeriPAN who are enrolled. All right, next we've got T-Chat. So for T-Chat, we've again got some similar measures and then just one new one. Engagement and care is the proportion of students who are enrolled in services who receive at least one treatment session. So once the student has been enrolled, the parent has consented to providing services, how many of them go on to get treatment sessions. The next measure is about timely access to care. This is something that team's been working really hard at, and it's the proportion of students who receive at least one treatment session who received that session within 20 working days of their referral. So it's teams working hard to get students and their families into care very quickly. Next is caregiver satisfaction. We also have a T-Chat satisfaction measure that is sent to caregivers and students at the end of their episode of care. And this measure reflects the caregiver's response to the question, I'm satisfied with my child's T-Chat services. On the next set, we've got the proportion of cases involving a parent or guardian, and this is a new measure that we're proposing for this year. This looks at students who have been archived with at least 2 sessions, either case management and care coordination or treatment sessions, where a parent or guardian is present. And parents and guardians can be identified as present as a part of both the treatment sessions and the way that it's documented, as well as case management and care coordination sessions. Sometimes those sessions happen at a different time than when the student is being met with in order to meet the parent's needs for flexibility. And so those involvement with the parent can be represented in that way as well. And then we'll limit this to those episodes of care where families have had 2 or more treatment sessions, so that we make sure there's an opportunity for that to happen. And then again, the final measure here is the percent of T-Chat leadership calls where the T-Chat lead is in attendance as well, year to year over date. So those are the performance measures across CPAN, PeriPAN, and T-Chat that we are proposing today. And we'll be excited to get feedback from the executive committee over the next month and a half, and we'll make revisions as needed before it comes back in August. So I'm going to pause again for any questions.
Very good. Thank you for, again, for all the work on it. Quick kind of thing I'm trying to think through on the T-Chat for parent satisfaction. It seems like some data that you showed me before that one of the leading reasons that parents aren't necessarily satisfied is because they liked it and wanted to continue, they couldn't continue. Is that correct? And I'm trying to think through how do we weed that out. The data are presented so that institutions are doing a great job. It's just that the confines related to the way the program is set up by direction of the legislature is not the long-term support of kids. Does that make sense?
It does. It does. That is definitely one of the qualitative feedbacks we get. Another one that we get pretty often is wanting to have more insight into what's happening and acknowledging that there's limits to that. That is a part of that, I think, the goal for that one measure. I'm trying to think if there's a way to, like, we don't have a specific question about that. We do have a question about whether or not they feel that any transition to additional services has been supported. So I guess in theory, folks who maybe don't feel as good about the transition services, that might impact their overall satisfaction. But I'm happy for any thoughts about ways to narrow down on that.
Think through that so that we don't.
Yeah.
Being institutions are doing, they love the service, but just can't keep on it forever. And then we get, they're not satisfied.
You know, Dr. Lakey, that's such a good point. And one of the things I know we used to show data, the COSH would present data sometimes about after the young person was finished with T-Chat, where did the referral go to, like which type of provider? And I think it would be really helpful to know, like from the time the TCHAT sessions were considered completed, how long did it take to get an appointment with a follow-up provider? Because I think that sometimes that affects also the parent's satisfaction, right? So if TCHAT was, finished, the treatment was accomplished like June 30th, and a referral was made to a provider in the community, but they couldn't get in to see the next provider till August. I think that affects parent satisfaction pretty significantly. And I think that data would be really important to have, just in terms of access to care and continuity of care post TCHAT.
Yeah.
That might be one reason why a parent would say, no, I'm not interested, or I'm concerned about being able to get in, because we know there's access issues.
Looking at the data overall, is to be high satisfaction by parent. I mean, like not mid 90s or so.
Yeah.
So. Olga, I think you were trying to get in.
Yes. I had a question both for kind of the reporting on the programs and these current performance measures. What source are we looking at that is looking independently about how children's mental health has improved in the state of Texas, outside of our surveys and outside of kind of the touch points that we have with our programs? What's the what is the trend looking like for children's mental health in the state of Texas? Is their mental health improving? What is it like a third party source? So yeah.
That's a really good question. I want to open it up to the external evaluation team as well. I'm not sure we have great sources for that. There are, we do look to things like the Youth Risk Behavior Survey, which surveys high school students, so it's limited in its scope, but it certainly does give us some information about those high school students in certain areas. And we also have the American Community Survey, which helps us understand a little bit more about ability to get access to healthcare services. But I think there's some limitations personally.
So we don't, there's not like an independent data source that we can look at to see if the mental health of Texas children has improved over time, besides these very delayed data sources.
Well, I think these are of course internal to our program, and we do have pretty rapid access to the data, but it does not speak to the public health impact fully. It does a part of it for sure, but not the overall public health impact that we think we're probably having in the state, as I think what you're referencing, that broader impact.
I am. Okay, thank you.
Lorraine, you want to jump in on this?
Yeah. Olga, one of the benefits I think that we have with the consortium is that it is implementing measurement-based care. And I think that's something that's relatively progressive in children's mental health. And I think just in terms of the consortium itself, because we're using measurement-based care, and when a young person comes into TCHAT, assessments are being, like validated assessment tools are being used to really look at, when they come into TCHAT, what is their presenting issue? So is it depression? Is it anxiety? For example, and then we can look at over time, when a young person's been involved in TCHAT, because it's short-term solution-focused therapy, largely, how those clinical outcomes have improved using those assessment tools. I mean, I think just in terms of the consortium itself, we could probably demonstrate improved clinical outcomes. I don't know in terms of, I think HHSC has outcome data that they track, performance data on providers that they fund. But I think there's not really a global repository of that information that
I think one of the challenges is weeding out the impact of the consortium versus post-pandemic increases that of an improvement in mental health that's occurring. There have been CDC documents that have come out saying overall mental health is better, suicide rates are going down, But weeding that out of what did the consortium do versus the post-pandemic atmosphere, I think is a little bit difficult, and one of the things that's going to take us some time to weed out. And you can also look at the absentee rates at schools and some of those things, but those have been a little bit harder for us to get in the past.
Okay,
Charlie?
So a couple comments. One is the Lancet just published the World Health Organization report on mental health, and they're comparing the 2003 to 2013 with the 2013 to 2023. And the data is not good. So overall, suicide rates are up. Mental health in children is more poor. This is globally, so not just the United States, but globally. But a more specific comment is one of the NECMAR projects, David, the larger project, is actually to track the TCHAT kids. This is the Shadula Benzer project, and we should be getting data. They already have data. I'm not involved in the project, but the whole purpose of that project was to determine the consequences of TCHAT and what happens after TCHAT. So I could mention to them that we'd like to see the data they have, because I think it's relevant to the question.
Margaret?
I was just going to mention that the National Survey of Children's Health does track anxiety and depression, and I believe ADHD as well. And that's going to be, I believe, housed by CDC or the National Survey of Health Statistics. And I believe those are like the official numbers, and they do allow for drill down at the state level. So that would be another source in addition to YRBS.
Yeah. But it is hard, I think, to sort out between a variety of societal things that are going on, pandemic, addiction to the constant bombardment our kids get through text, media, et cetera, that's taking place. And then on the other side, the consortium work and the support that's taking place.
I also do know that from a provider perspective, we've heard from the provider community that the acuity of youth who are coming into care is higher.
Yeah.
And they've seen that increased over time since the pandemic, as you mentioned.
Yeah.
So.
And so a lot of our measurements right now are based on parents and do the parents believe that their kids are better after receiving the services? Dr. Salas?
Yeah, I was just going to jump in and say this is where the importance of evaluation, even really of our program, is a strength to understanding that, because we know impact is reach times effectiveness. So we're monitoring very closely between the external internal evaluation reach of schools, clinics, children within schools, within regions. And if the care, which we know is evidence-based care, is implemented with fidelity, then we would know that we reach times that effective care is impact within the program. I mean, that's why, like, in the logic model, we have these long-term outcomes, which are harder to measure. But if the logic and the evidence of that logic is true, then we would know those long-term outcomes are going to happen. Yes, they're hard to prove, but those logic model linkages really do lean on the research and what we know is effective in previous research. So anyway, just putting that out there to remember that schematic, and it really does build on the evidence. It's informed by the evidence.
Yeah. Olga, it's an important question, and a question that the legislature increasingly is going to be asking.
That's why I thought it'd be good for this group to talk about it, Dr. Leakey, right? Because as you mentioned at the very beginning, as Nagla mentioned, it's going to be one of those sessions. Everyone's kind of talking. It's going to be, it's going to be one of those, and they're going to be asking everybody questions like that. So, it's as I'm listening to these really great presentations on the number of children touched, number of schools impacted, the future performance metrics, all of it, right? I'm thinking of your output measures, your outcome measures, and qualitative, really important. And so when decisions are made, it's like, okay, so how many years we've been doing some really great work over these years. And so how it's more of like how have we impacted the trajectory, or how have we improved the mental health of kiddos in Texas? And so, as Dr. Nemiroff said, there's going to be some data that says it's only getting worse and more acute, and yet we have a lot of touch points as well. And so, what is the when any of us are asked, Dr. Leakey, right, in any settings, how do we communicate the complexity that we're making a difference, especially in workforce and other areas, right? At the same time that children's mental health issues are getting worse and more acute.
Yeah.
That's the part. So
I think the workforce ones are pretty easy to demonstrate.
Yeah.
So many
Yeah.
people, and now we have more people, and that's pretty easy.
yeah.
I think with CPAN and PeriPAN, the utilization of supporting primary care providers and the decreased referrals to big cities, I think that's easy. The question, a lot of it will be on TChat. And again, I think it's hard to tease out because of societal issues. But we can show the data for how do parents think that their kids are better. Nagla?
I was just going to add, I don't know if this works. Okay. I was just going to add that we do have the data, as Luann said, about the measurement-based care. There are additional measures that are not part of the performance measures right now, because these are called observational measures that Molly did not present today, but that are trying to get to a point where we can look at that data and feel comfortable with the data, the way it's presented at a HRI level, et cetera. So we started collecting more standardized measurement-based care. And there's also work for the external evaluation as they're looking at some of those long-term outcomes, that they're starting to look at other sources of data, like the Texas Education Agency data, and other sources of data to kind of assess those long-term. It is a process. The data, just like any other data, the quality of it, the availability of it, changes that have happened over the years, et cetera, may make it a little bit more difficult. But I think those are things that are on our task list that we will continue to kind of move towards.
Any other discussion before we move on? Just watching the clock. All right. Hearing none. Molly, let's go back to you related to the Local Mental Health Authority pilot evaluation findings.
Thank you. Okay, one more thing from me. Okay, so the executive committee has received updates over the last year, really, on the TChat and LMHA pilot, but it concluded in May, so we're pleased to be able to share some of the results of the evaluation with the committee this afternoon. Okay, so just to give you a little overview again, the TChat pilot, this was led by Dr. Pliska, and Rachel Jew at UT Systems provided sort of that backbone support for it. The goal of the pilot was to establish or strengthen those partnerships between the HRIs and our LMHAs or LBHAs, really for the goal of students who no longer need those services from TChat, who are moving into longer term services, to make that referral as smooth as possible to community mental health. HRIs and LMHAs applied to participate. There was no funding involved, but they volunteered to be a part of the pilot, really with the goal of exploring some of the best practices for those partnerships. At the state level, we have participation from UT Systems, from the Health and Human Services Commission, and from the Texas Council of Community Centers. And then HRIs who were participated included Dell Medical School, Texas Tech University Health Science Center, University of North Texas Health Science Center, and then UT Health in San Antonio. And the LMHAs or LBHAs who are part of it were Central County Services, Star Care, West Texas Centers, MHMR of Tarrant County, and the Center for Healthcare Services. The pilot was really structured around a learning community where participants worked together in their partners to develop those local referral processes and communication strategies that worked for them. And then they brought those lessons back to the broader learning community so that everyone could learn from the discussion about what was working for different partnerships. The pilot began last April. We actually extended it. The EC voted to extend it in September since the referrals are kind of slow during the summer. We felt like we needed a little more time to learn about the process. And so it concluded in April and we wrapped up in May. So the evaluation, we really aimed in that to understand the changes to kind of those baseline practices that were happening before the pilot. To understand whether the changes that were made were helpful, whether they were feasible to implement, perhaps to expand to other HRIs and LBHAs, and whether they were sustainable really beyond the pilot initiative. We also wanted to know about rates of referrals to the LMHA and LBHA, which was something we did not have in our standard data, and the types of barriers that were experienced in that referral process. We tried to really keep the evaluation activities as streamlined as possible to minimize the time commitment. Our team reviewed the materials that arose during the pilot. Most importantly, teams created protocols and procedures for those referral processes, and so we reviewed those. And then HRIs also reported on the data that's on the students who were identified for referrals and then tracked them through the referral process. And through that data, we also looked and learned from the barriers that were experienced along the way. We're using some existing data in trait from students, both those who were referred to the LMHA, LBHAs, and then those who were not referred as well. And then lastly, our team conducted interviews with all of the participating organizations to gather more information about the context of the work that was done and the learnings that were developed. And we really appreciate the time that was provided by all of these different partners, both for the Learning Collaborative, but for us in particular for those interviews and kind of learning from what they had experienced. So I'm going to kind of follow up with some of the core findings that we had for discussion. So I'm going to start off with just some of the things that the teams did as a part of the change process. First, here we have some of the common activities that were across all of the partnerships. So the HRIs and the LMHAs identified those students or families who they felt were most likely to be eligible for services within the public mental health system. And then they talked as well about those mental health services that are available within the LMHA, and then any limits on capacity, right? Are there wait lists for certain services that should be taken into consideration? The LMHAs or LBHAs also kind of let the HRIs know what information they needed that was going to be most helpful for the referral process, that was going to help speed up that access into care. And then all referral procedures began with the guardian providing consent for the HRI to share information with the LMHA or LBHA and a release of information for that process. And then HRIs and their partners each identified key liaisons, so key contact information, and then established some regular communication channels to facilitate these conversations. So on the next slide, I've got some of the somewhat common but also somewhat unique procedures that were created as a part of this process. Everyone created some sort of process for referral through a dedicated channel. These are a few of the different ways. So some sites developed a process directly through their EHR workflow to communicate those referral processes. Some created a dedicated email at the LMHA where a liaison then was there to take those referrals and start the processing. And then other partners created a shared tracking spreadsheet that both could access and kind of follow along where that referral was. In addition, there were expectations, and they varied, but set for after the referral comes into the LMHA, when can they expect for the LMHA to reach out to that guardian to set up a time for screening and then an intake appointment. There was also in one partnership, an indicator that was provided for an urgent access need where there was a shorter time frame for the LMHA to get that intake appointment set up. And then each of the teams developed some ways to communicate confirmation of that established appointment so that they would know that that intake appointment had been set. And then the TCHAT team usually delayed their discharge of the family from services until that linkage had been successfully met, or there was a recognition of a barrier that was probably not going to be overcome. So those are some of the different ways that changes happened across the partners. Okay, so our first key finding on the next slide is that referrals to the LMHAs and LBHAs were lower than was initially expected. And so what I'm presenting here is information about the number of students that were archived, so closed out of TCHAT services during the time period of the pilot study. In the next column is the percent of those students who were referred for mental health services. There are other things that students can be referred for in TCHAT, and so those were excluded from this look. But for those who were referring for mental health services that in theory could happen within an LMHA or LBHA, so excluding like intensive outpatient or inpatient care. I mean, you'll see that there's variability, but a fairly substantial number of students are referred. And then that following is the number of students who are identified for referral to the LMHA or LBHA as a part of the process. So there was some variation, but you'll see in general, under 5% of those students were identified for referral. And we had a lot of discussion about that. I think there's still more to learn than we were able to learn initially, but I think it was helpful to hear from the HRIs that they really felt like many of the students that they were referring maybe didn't need that level of intensive services that are offered by the LMHAs. So the next finding 2, gets a little bit more to this. Therapy is really the primary referral need following TCHAT as identified by the HRIs. And we see in the overall data that 80% of those referrals following TCHAT were really for individual therapy. While LMHAs do offer some individual therapy, it's really not the primary service that's provided in the child and adolescent services. And some LMHAs had limited capacity for different individual, group, and family therapy opportunities. But important to note, participating HRIs generally found that they could find community referrals for therapy outside of the LMHA, LBHA, so they didn't feel like students were, their needs were not being met by not referring them to the LMHAs. And then there was some also feedback as a part of the interviews that TCHAT providers may still not have kind of all of the information about the types of services offered by the LMHAs and the LBHAs, especially some of those specialized services, because they're not widely available in other settings and may not be a part of kind of what we think about in terms of a array of services. For example, you know, wraparound care or coordinated specialty care may be sort of more unique to LMHAs, and that may not be as readily accessible in terms of thinking about referrals throughout the HRIs. Okay, next finding, finding 3. This shows a little bit more about the number of students as they move through the referral process. So in that first square, we've got 61 TCHAT students who were identified as being appropriate for an LMHA or LBHA referral. And you'll see following that 47 of those students were actually referred to the LMHA or LBHA. And then underneath that arrow is what kind of happened to those students that dropped out of that transition process. So there were some parents who were not able to be reached at that period of referral. There were some parents or guardians who declined the referral to the LMHA. And then there were, this was kind of early on during the process, some challenges reaching the LMHA contact early on, and then a few instances where it wasn't clear what happened as a part of that process. That was not the biggest area where students or families kind of fell out of the process. It was really the next phase. So after the students who were identified were referred to the LMHA, we only had 16 students or families then go on to have an intake appointment at the LMHA or LBHA. So what happened to those students? Well, the vast majority were instances where the LMHA or LBHA had difficulty reaching the parent or guardian, couldn't contact them directly, they were not calling back, and so struggling to kind of make that connection. There were a couple of parents who declined. One instance where an LMHA did not offer the service that the family particularly wanted, and a few unknowns. But this was really kind of the finding of where most of the referrals kind of got dropped off. And so just to kind of finish up that referral loop, of those 16 who had an intake appointment, 10 went on to be determined eligible and have additional provider appointments. But I want to note that only one of those parents failed to engage at that point in the process, and 5 were unknown. So it is possible that those 5 continued on and got provider appointments as well. That was just area where we weren't able to close the loop. So I think some important things to take from this is just the challenge of having a referral from one provider into what could be a kind of complicated system to get access into was an area where we lost some of the traction. But once families made it into that intake appointment, they were generally found eligible and moved on to having engagement in care. All right, one more finding here. Finding 4 is that both HRIs and the LMHA and LBHA partners found a lot of value in the regular meetings that they had in having those key liaisons and in formalizing the referral procedures. Having contacts on both sides, and people reflected having somebody who's very responsive when they reach out was super helpful on both sides to making this work. They found that referrals were less challenging than in the past because there was a specific process that was put in place and that it was super clear and documented about how it was going to work. But they did find some continued misinformation or miscommunication along the way about kind of the characteristics of the child and family that might make a good referral, as well as some of the services that are available. And so in general, as we were having these wrap-up conversations, folks felt like there was a lot of progress made, but still some additional work that could happen around clarifying and continuing to build and strengthen those partnerships. And both the HRIs and the community mental health providers said that the pilot wasn't fully successful in closing the loop consistently for referrals. They felt like more could be done over time, but there were a lot of great lessons that were learned. And then on my final slide, I've got a few recommendations, some broad recommendations here. So one is to provide some additional information and training to HRI staff responsible for planning and making referrals to make sure there's adequate understanding of the specialty populations and services provided by the LMHA and LBHAs and the levels of care and how those levels of care that the community mental health system uses to match students and families to services, how that process works. And excitingly, some of that's kind of in the planning and in the works for the upcoming TCHAT Summit. Next is developing direct communication pathways was a low burden way to communicate referral information, and this piece should be replicated in other HRI LMHA pairings that were not a part of the pilot. Another recommendation is that HRIs should continue to integrate regular meetings with their community mental health partners to continue to build this understanding of services and capacity, as well as problem solve specific student referrals. And then the fourth recommendation on here is really kind of a recommendation and a bit to this collaborative, because it includes such a nice partnership with HHSC and the Texas Council and other components of the system of care, is to explore those opportunities to strengthen navigation support for families who are transitioning from TCHAT or other mental health care to the public mental health system, maybe as a first priority, but to also to other community mental health providers. And that aligns really well with some of the discussion that we've been having about the challenges sometimes in kind of that next piece of longer term care when that is needed, and how do we strengthen those pathways so we can make sure that families get access to the care that they need as a part of that process. All right, so that was a lot. So I'm going to pause again and see if folks have comments or questions.
Molly, I think we shouldn't get too taken aback by the results of the 61 referrals. It's a very small number. And I don't know where, was it a particular HRI? Was it more than one HRI? But I think, yes, it is true that drop off from referral to success is difficult, and it's different in different regions, as you know. So 61 is just too small a number for us to say that out of the 61, only a few of the patients ended up getting seen. You're absolutely right about the issue of evidence-based psychotherapy not being the mainstream of local mental health facilities, and that's the reality. So I just don't want everybody to be discouraged. If we had a larger sample, we might end up seeing better now.
I think one thing that was a bit of a surprise is that the HRIs did not have a large number of people to refer, which was different from what we heard when we went into the pilot. Mm-hmm. We were hearing from the TCHAT programs, we've got a lot of people. We need to get into the services the LMHAs provide. But then we would have our weekly meetings and we say, how many you referred? Well, we didn't refer anybody this week. How about that? Well, last week before that, no, we don't have anybody. Well, this month we referred one person. And then we went back to the TCHAT leadership committee. And I said, hey, folks, this is what we're seeing. Nobody came back and said, oh no, Dr. Pliska or Molly, there's lots of people who need to go. They said, yeah, that's kind of about right. So that suggested to me the folks in TCHAT were either getting better with TCHAT, and I think that was happening a lot, or when they moved on, they went to lower levels of care, back to their primary care, to their local psychiatrist, to their community mental health clinic. And these people who needed services for the seriously mentally ill were a smaller proportion of the TCHAT population than we perhaps realized. And that may be a good thing, that TCHAT is dealing with that mid-level of severity where we're perhaps maybe even having a preventative effect.
Okay.
I appreciate that. I think too, that may be a reflection of the work that's, sorry, I'm not sure why I'm doing that. That may be a reflection of the work that's been done supporting the TCHAT liaisons at the schools and really understanding who's appropriate for TCHAT, who should be referred directly to the LMHA for that service. And maybe, we're getting the right kids into TCHAT and the right kids for the LMHAs as well right away.
So Molly, a quick kind of process question, kind of what's next? So you have your recommendations, you have the report. Is that going to be something that gets put into if you have a PowerPoint, will that be put into a report that will be shared across the consortium or published, or kind of what's next with this?
Yes, that's a great question. We do have a report. It's drafted and getting close to a kind of a review process. It will have a little bit more information about one of the things that we are excited, even though it is just 61 individuals, is we do know who those young people are in terms of how they show up in trait. We don't know who they are. They're anonymous, but we will be able to look at some of the data about their functioning, about how they compare to other students who are maybe not referred to the LMHA, just to get a little bit more insight into the process. And then, yeah, that report will be coming out pretty soon.
All right, very good. Olga, and then Lee.
I had a question for Lee. I said, Lee, so I defer to Lee because I wanted to know what he thought about these results.
Yeah, so I guess I'll step in here, Dr. Lakey. I just, I want to say thank you to Dr. Plitzka and to the other members on the team for the work on this. And, I would like to reiterate, I mean, I think the biggest takeaway from this is that, when this whole conversation first started, there were a lot of concerns about HRIs not being able to refer people and the high volume of people they needed to refer. And I think the one takeaway that is really good here is that really does not appear to be the case. That was, of course, highly concerning to our folks who were, of course, we were going and saying, here are the dynamics that we're hearing. And so to have an effort like this that really zeroes in on some of those things and kind of gets to the root of what's going on, it was really key. And so I think that's a great takeaway from this. The other thing I'll say is, Dr. Plitzka, I really appreciate you coming to participate at the April quarterly meeting. So for those of you that aren't aware, all of the executive director CEOs in our system meet on a quarterly basis here in Austin. Dr. Plitzka came and gave a great presentation talking about some of this and some of the hopes that we have for long term. So I'm hopeful that kind of collaboration will continue to exist. And then even in regard to the summit that was previously mentioned, I think there's some opportunities to further solidify some of the things that we learned from this. But I think from our standpoint, we're not discouraged by the lower numbers. There's some confirmation of kind of the dynamics that we know that exist in thinking about the population that TCHAT's serving and the population that our system and the public safety net is serving. And so those dynamics, there's some confirmation of that. But I think moving forward, a really key takeaway is increased collaboration. And so that all of the HRIs and all of the local mental health and behavioral health authorities are talking with each other, collaborating about these things, and developing processes and procedures that help folks, more easily move between systems when that's necessary. So I think there are a lot of good takeaways here, and we certainly look forward to efforts in the future to learn from this, to continue learning, and to improve both systems.
Yeah, very good. Again, thank you, Molly, and thank you, Lee, and thank you, Steve, and Rachel was very involved in it, to all the individuals that were involved. I think this is why you do pilots, right? You do it and you try and you figure something out, and then you tweak it and you share that information. So I look forward to the continued conversation. All right, we have two more items on the agenda today. Margaret, let's go to you for the update on the new and emerging child mental health research grants.
Yep, thanks, Dr. Lakey. So I'm here to talk about the upcoming funding cycle for NECMR. And the most important caveat slide is going to be that the FY 28-29 awards are contingent on legislative funding. This initiative focuses on advancing the knowledge and evidence base in the prevention and treatment of childhood mental illness and supporting the training and research of new and emerging researchers. The research must be related to improving the child perinatal mental health system and/or child perinatal mental health services in Texas. It also may include gaining an understanding of the causes of childhood psychiatric disorders. Basic bench research and pharmaceutical clinical trials are not eligible. And finally, once promising evidence-informed practices are identified, Findings will be disseminated to inform providers, policymakers, advocates, and families about the specific types of treatment approaches that can minimize the symptoms of childhood mental illness, promote recovery, and help all Texas children thrive. There will be 3 types of grants. Next slide. The research career development, postdoctoral fellow and trainee, and research project. So who's eligible? Only those affiliated with one of the TCMHCC's participating health-related institutions are eligible to apply. Principal investigators may partner with Texas-based investigators at non-TCMHCC institutions as needed. Prioritization will be given to applicants who have never been in an NIH R01 grant principal investigator and are at the rank of associate professor or lower. Trainees, including clinical and research fellows, are eligible and encouraged to apply. Proposals that include more than one TCMHCC institution are encouraged. All right, for research priorities, like in past cycles, we have incorporated the research priorities based on input and feedback from the following agencies and groups that you can see on the slide here. Next slide. We do want to encourage cross-institutional mentorships. So senior faculty at TCMHCC HRIs will provide mentorship to any applicant from any HRI. As part of mentorship, they would provide input to the researcher related to their proposals. If the researcher is awarded the grant and the mentor is identified as a mentor for their grant, they would assist the researcher and guide them along with their research and publication of findings. They would have a 5% salary support using the 2024 NIH cap if they were included on the applicant's proposal. We received mentorship interest from about 8 senior faculty and clinicians. So here's our current timeline. We're aiming for the NOFO to be released this month. We will have a Q&A session. They're scheduled for later this summer, one for July 30th, another for August 5th. The pre-application is due September 30th, and full application invitations will be sent out on October 1st. The full application deadline is February 1st of 2027, with the award starting September 1st of 2027. And finally, we can take some questions specifically about NECMR, but we would also like to have a separate and yet related discussion around if TCMHCC can increase research dollars for the next session, what should the priorities be? Would a program modeled after the NIH T32 program be beneficial? And if so, would this be a different application process from NECMR? And how do we make sure it's fair to all TCMHCC institutions? And finally, what changes do you recommend in the NECMR program?
So I'll jump in here and again, thank everyone that has participated in this. Again, we have the opportunity to be a little bit novel and how we are building out the various mental health programs we need in Texas. And one of the things from the beginning is trying to improve research related to mental health services. So NECMR is designed, as we've gone through, to do several things. One of them is to build that cadre of young investigators that our institutions need to be successful to bring in additional funds to the state of Texas. And I think we have a good track history now of funding folks over 2 cycles, and about $8 million we've put into this. We've also tried to make sure it's focused on things that the state sees are needed. It's more health system research. And so again, appreciate all the state agencies that have told us what they believe are the needs and programs that need to be discussed. And Charlie, as you brought up earlier today, an example of how a NECMR grant can be helpful in identifying a specific piece of data that we need, but it's just one of many examples. But as we, again, are approaching the next session, I thought we should have a little bit of discussion of, is it meeting the needs? Do we need to think through the priorities? I work with another group on a different area that's doing research, and one of the things that they saw that would be very helpful is trying to develop what's called a T32 grant cycle. It's something modeled after it. For those of you that aren't familiar with that, it is a institutional grant that goes to obviously HRIs, other academic institutions, so that they can build research programs and have basically several slots that are available to offer promising researchers. It's awarded based on the track history of those institutions on educating individuals and getting them to be successful faculty. And when I look at the data overall for the state of Texas, Texas is lagging woefully behind other states related to T32 grants. So, if we were able to get more funds, do we just put up more NECMR grants? Do we think about maybe doing something maybe a little bit different? And if we did something a little bit different, how do we make sure that that's fair so that it just doesn't look like a way to award the large research institutions versus making those opportunities available to everybody? And so have a little bit of time just to, and you don't have to give us that feedback right now. As you can see, we have a timeline on this, and we'll be approaching the legislative session, but it's something that I would like to get some feedback from individuals. Obviously, we can't award these grants until the legislature says, here's the money, but we want to start the process early so that as soon as the money is available, everyone knows who's going to be awarded those grants, and we can jump in very quickly. And so let me just kind of open it up and see if there's any feedback from anybody. And Charlie, if I was to bet, I was going to bet that you'd be the first one to jump in.
I have a lot to say here. So this has been a wonderful program. I think one of the things we need to do for the legislature is to track the progress of the previous awardees.
Yeah.
Right, as to how many have they applied for NIHK awards? Have they garnered any NIH awards? What about DoD, other extramural funding, foundation funding, their publication, so that we could say, hey, look what we've done, because we were woefully behind. I think your idea of a T32 is terrific. I think we need to be sensitive to the different institutions. But I think it's a wonderful program. The other point I'd make is that, there are always debates at NIH about trying to discuss priorities versus letting the field define what's best. And I think we need to strike that balance between recommendations about, we'd like to see this or we'd like to see that versus what does the field see as what's important, and that balance is important.
And if I may jump in, we haven't limited it to those items, but we've put that out, and if it's directly aligned with, as HHSC saying we really need research, I think that's been a bonus for the applicant. But we haven't said that if you want to do something different, except for the parameters that this isn't pharmaceutical research. This is the basic things that we put in. Which we believe are in line with the direction of the legislature. Dr. Raji?
Yes, thank you. And I agree with everything that Charlie said. I do really like the T32 mechanism. I mean, I agree there is a lack of, not enough of them in Texas. And I think one way to, as initial thoughts, one way to think about is that to part of the criteria, part of the design of the T32 mechanism is to have potential applicants, fellows from smaller institutions, training and cross-exchange between the larger institutions so that we provide access broader, not limited to the large institutions. The other comment I would make is that I think, I mean, there is, we could be explicit in terms of the scope of the intervention, the scope of the studies. Some of them, like a certain chunk, would be dedicated to actually evaluating, kind of to the earlier discussion we were having, evaluating a lot of the activities that we're doing at TCMHCC. So there is, that could be like a third party, an external type of evaluation. So if we dedicate part of the NECMR awards to that evaluation, and then let's say another part of it open to whatever comes out. The last comment I would make, I think when we talk about pharmaceutical trials, sometimes inadvertently, I think a lot is lumped under pharmaceutical, like any industry related trials. So what I'm thinking about in Texas, we have strengthened neuromodulation, which is not pharmaceutical, actually is meant to reduce pharmaceutical in the trials. So being mindful of what are some areas of strength we have in Texas that could advance the field of children's mental health. I mean, that's we don't want to just miss the fact that these are strengths that are not really pharmaceutical, but sometimes they can be conflicted. But going back, I think the T32 mechanism of the
Yeah, very good. Dr. Suarez?
David, I really agree with everything that's been said here. I'm very enthusiastic about adding a component for the T32s. I don't think we have enough of those across our state. I believe that could be very impactful, helpful. So thanks for pointing that out.
Okay, very good. Any other comments?
Oh, Dr. Wagner.
Dr. Wagner?
Yes, I'm definitely in support of all of the things that have been said. The T32 is very important. I would want it added on and just hopefully not to decrease from the number of NECMA grants.
Okay. Good feedback. All right. Again, thank you for that feedback. If you have any other feedback you'd like to give to us, just go ahead and send me an email, and we work on finalizing the information we'll be sending out. Let's now go to Kelly. We're going to go to you related to the proposal for disaster response training and deployment hub.
Awesome. Well, thank you all so much for allowing us to come and speak and present our idea. So essentially, and we can go to the next slide. We're looking to not change much. So it would be that San Antonio is able to provide a standardized training for disaster response prior to disasters that happen in our state. We would be able to also keep the roster of the required trainings for people who are deployed to disasters based off of what HHS and the disaster behavioral health team has put into place. It would allow us to have more rapid deployment and coordination of those efforts across all of our HRIs. And then we would provide evidence and evaluation. So we would be able to do data collection and then have peer-reviewed dissemination and translation of evidence into the updated training protocols. So with this, we know that Texas has a lot of challenges. We have a very disaster-prone state, whether it be hurricanes or floods or wildfires or tornadoes or you name it, right? We kind of get the gamut here in Texas, and we do have them occur quite frequently. Children, we know, are most affected by these. Our kiddos, I have not ever been on a response where we have said, hey, we have too many child disaster behavioral health responders. And a lot of that is like our culture in Texas. So I'm a Texas parent, and when disaster hits my community, I am most focused on my children and are they okay? And what do I need to do to help them get through this and to have post-traumatic growth, right? Before I can even worry about my own well-being. So with that, TCMHCC, we were built to expand on the infrastructure. We were built to fill in the gaps, and that's essentially what we're proposing. The TCMHCC staff did phenomenal. I hope that we never have another disaster during legislative session because I cannot imagine the work that put on Nagla and Rachel's plates. because it was a lot. And I know that coordinating a disaster response team to go out is a lot. So with this, we've always looked at our workforce and started to enhance that in many different ways across our institutions. And so disaster training for our workforce, it multiplies in what happens for those that stay with consortium, for those that go on and have careers outside of consortium programs, they're then able to be trained in their own community. With that said, so we responded as a consortium to Uvalde and to the Hill Country floods thus far in our 6 years. And overwhelmingly, when staff has responded to these events, they always are saying, I wish I had more training in this. I wish I could get more formalized training. Where do I get training? So this would be an opportunity for us to pour into our workforce within the consortium. With that, we also bring something to the table in disaster response. We have the trust of our schools. Our HRIs are connected with our schools. We have those relationships. We also have relationships with the LMHA in the area, wherever it happens. I can tell you after responding to disasters, the relationship with the responders who are also from the LMHAs from across the state and their amazing model that they do now with the rotating and support, it has been invaluable to our TCHAT program and to our CPM programs. So with this proposal, we are not saying that San Antonio becomes the lead of everything, because no. If a disaster hits in Galveston, then it would be the UTMB team that would take lead. They know those communities, right? So your boots on the ground lead could continue to be your HRI that is in that area. With that, what we're offering as our San Antonio hub is training, lots of training. So we have both NOVA and SISM trainers within our hub to follow those protocols and provide that disaster response actual training. We have a history of being collaborative and connected within our response agencies. So with STRAC, with TITA, with first responders across Texas, we have a historical relationship with them. We also have longstanding relationships with our LMHAs, disaster behavioral health, STRAC, and we're going to essentially offer these 4 things. So our statewide training coordination, it would be looking at NOVA for the training model for the community response model. This is consistent with what we're seeing happen with our DBH teams and with our LMHAs. Both have been being trained in NOVA. Our DBH team has also gone above and beyond. Shout out to them who are now trainers in NOVA. So they really are embracing the same language when we go on a response. We're going to look at pediatric disaster triage, mental health needs and assessments, looking at, getting some CEUs involved and some CMEs, and then having response meetings. When a disaster happens, we would be able to help with the deployment coordination by keeping a registry of who has done their FEMA trainings, who has done their NOVA trainings, who has been certified, and being able to put that out so that we're not, as an HRI, scrambling to say, hey, anybody, everybody who wants to go. We're able to do a more specified response. And disaster is always volunteer. So if there's somebody in the consortium that doesn't want to train in disaster, don't train in disaster. It's always on a volunteer basis because it needs to be people who are willing and ready to do that work. We'll continue to coordinate with our regional advisory councils and STRAC and with our HHS disaster behavioral health. To be utterly and completely clear, we do not, and it will not change. We won't be responding without the activation from HHS disaster behavioral health. We will come in at the invitation of our LMHA. We're going to follow we're not recreating a wheel. We're not adding in. For those that have done disaster, we know the problem of convergence on a disaster response, and TCMHCC is here to fill the gaps and support the need, but not to take over anything. So we are there in the same methodology that we have been. It will have cross HRI governance. It will have an advisory committee across all the HRIs so that everyone is in the loop and be able to have technical assistance for HRIs in our communication and making sure that we have a single point of contact for mental health matters as they arise. And then we'll also provide the data and evaluation. We'll get those after action reports on the daily, on the weekly, to be able to report those numbers up. We will be able to do quality evaluations and see, you know, what could be better next time. What can we do to enhance what we're already doing? And how do we better serve Texans when they are in this situation of a disaster? So our timeline is if we are have the formal designation, we'll go ahead and hire that disaster response coordinator. We'll start building that advisory committee and landscape the assessment of our disaster response capacities. Then we'll be looking to standardize the training curriculum and develop the protocols. By phase 3, which is in the first year, we'll at least train 2 other HRIs. More than that could be done. The goal is to train as many as we can, as quickly as we can, and then continue that training moving forward. The state 4, we will give TCMHCC update on it. We will publish our year 1 evaluation reports, and we will definitely keep everyone involved. Annually, we'll give NOVA training. We'll do the rosters, make sure that we have people trained and ready to go. We'll do ongoing training revisions based off of feedback. We will have our responder meetings, our advisory committee meetings, and we'll give an annual evaluation improvement report. If and when a disaster happens, we'll provide all the after action reports, the pre and post deployment briefings with the TCMHCC responders before they go on deployment and then after they return. And then we'll do feedback surveys and quality improvement based off those feedback surveys. So overall, in conclusion, TCMHCC has done a phenomenal job on these disasters when they've occurred. I've mentioned the large scale disasters, but I know that across our HRIs, we're responding to smaller ones as they occur. And so it may not be a state coordinated effort in those, but it is also valuable to have your staff trained for those times. We would be able, hopefully, to transform our state's capacity. So one of the things we always hear from responders from other states is how amazing Texas does it and how great we are and how they're going to take this back and implement it there. I'm extremely competitive. I like to stay number 1. I think this is a way for us to continue to shine and outdo what other states are doing. And yeah, we stand ready to train responders and coordinate the efforts if that is something that the consortium desires.
Very good. Let me just jump in real quick. As was noted, we've had 2 big disasters that we got called into service on. The first one being Uvalde, and Luann, I remember you and Monica in a room trying to figure out how do we contact everybody and pull in the right people and make it work. And you guys did, and we leveraged San Antonio because it was in your area of the state and got them linked to T-Chat services moving on. But it was a system-wide response where we had people from all over. And the direction that we gave everybody is put down your institutional flag. We don't care what institution right now, you need to be part of the consortium. And then we had the floods last year and had the same situation where very rapidly we were putting things together. For those of us that have been involved in disaster response, it's very clear that you have to have an organized response and it needs to plug into this overall state plan. The last thing the state wants is a loose cannon out there that's just responding on their own and not plugged in. And that happens. And I have been in responses where I've been in charge of where somebody shows up and the next time you see them, they're in front of a TV camera trying to explain why they think the state should have done it a different way. And you can't have that if you want to build the trust of the people we're serving. And so we've talked to TDEM, we've talked to HHSC, gotten feedback. We will very much plug in to their plan. We have a good relationship with them, but again, it's not just handing this off to San Antonio. It is part of the consortium, and we'll be coordinating that with us, with our input and with the other state agencies that are involved in disaster response. The but that allows us to be incorporated into their plans on the front end. It allows us to plan, it allows us to get the training and make sure that we have people ready to go. So when the event occurs, we can rapidly do this and not have people that are walled off in a room trying to make this happen very, very quickly. And so, Lee, I see that you have a question. You want to make a comment?
Yeah, thank you, Dr. Lakey. Just a comment. I want to say thank you to all of the HRIs that have been involved in this. Those of you that know and have been involved in the response, you know how critical it is to have backup. Our local mental health authorities and local behavioral health authorities have a statutory responsibility to respond in a disaster. And we do that through our engagement by HHSC and then the local incident response command structure that exists that goes all the way through the state level, actually, and into the feds. But we have benefited so greatly from the partnership. I think about our folks in Kerrville. A few months ago, we were in Washington, D.C. at the National Council for Mental Wellbeing's annual conference and had an opportunity to tell the story that happened in Kerrville. You all know that when you're involved in these things, very often you don't get to tell the story about what happened. You just focus on the response and helping a community come back together. They gave us the opportunity to tell the story. And on Thursday this week, our annual conference begins Wednesday afternoon. And on Thursday morning, we're doing a session here in Texas with leaders from all across our state to tell the story again. And a featured part of that is the engagement and collaboration with the consortium. And the fact that UT Health San Antonio had folks at the ready debriefing staff that went in and came out, and all of the other engagement with first responders and other people in the community. These are incredibly difficult things that communities deal with. A disaster happens in every community. It could be a natural disaster or a person-made disaster or whatever that happens. And so we're really grateful for the continued involvement here. And I just wanted to take a moment and say thank you.
Thank you, Lee. Olga, you had a comment?
Yeah, I had a question. First of all, Kelly, thank you so much for presenting this proposal. Question on legislative authorization. And so I know we've been very particular about that and the funding that's been appropriated for specific activities that's been authorized. Can you speak to kind of how that would work, Dr. Leakey?
I think the statute is broad enough that related to addressing mental health services. It's more of a leveraging of our TChat services, a leveraging of our CPAN services. It'll be integrated into the overall work that we are doing. The cost is actually pretty minimal because we have the people that we're bringing to bear are the people that we are already paying their salaries for. And then there is a coordinator type activity that takes place. And so I think it's consistent with addressing the mental health needs of kids and leveraging the system we've built in the midst of the crisis, as we've been called upon twice already to do. Any other questions? All right. So I would take a motion for approval of this hub for disaster training and deployment. I have a motion by Dr. Nimrod, second by Dr. Plitzka. Any further discussion? Hearing none, all in favor signify by saying aye.
Aye. Aye.
Aye.
Okay. Opposed, nay? Anybody abstain? Hearing none, let the record show that we had unanimous approval to move forward. With that, I think we're done. So if somebody wants to motion for us to adjourn, I'll take that motion. So everyone's motioning for us to adjourn. All right. Anybody object? Thank you all for your time, and we will keep in touch over the summer. Thank you.
Thanks.